Okay. Thank you all for having me today. Thanks for the organizer, Dr. Imad, and everyone. I first we're gonna start to apologize. I wasn't able to be with you all in person since I have a great meeting yesterday. I had uh, Paris' daughter decided to show up yesterday, and she kept me busy from coming. And I'm just gonna go quick through my slides. I know it's a short time, and I will try to cover as much as possible. So, as you all know, gastric adenocarcinoma is the it's the fifth most common cancer worldwide, and the fourth most lethal. It's mostly asymptomatic in the early stage, and it could when survival rate are highest to 90% with minimally invasive intervention like surgical or endoscopic resection. Okay, so GIM is as you all know, is a persistent and pre-malignant lesion in the stomach that arising from chronic inflammation, which predisposed one to gastric cancer. So globally, the risk all associated with H. pylori infection, as you all know, it's well recognized class 1 carcinogen. Around 50% of the population in the world are infected with H. pylori at least once in life, and this is mostly considered predominant cause of 90% of non-cardiac gastric cancer, which is the most common we see. This slide is pretty much talking about the basics how the progression started from normal gastric mucosa up to the gastric cancer. It's very important to know all the stages where we can tackle some of the steps where we can prevent cancer. So normally when you have a normal mucosa, you get chronic gastritis, atrophic gastritis, then intestinal metaplasia. Up to this point, when you treat H. pylori infection, you can eradicate it back to zero. Once you have low-grade dysplasia, you still have a chance to treat H. pylori and radiate it back to intestinal metaplasia and still prevent cancer. But once we reach the stage of this high-grade dysplasia, I think we are entering the most dangerous area and think the intervention need to be done as soon as possible. This picture just highlight the importance of to all of us as endoscopists, sometime when we do a fast endoscopy, we tend to look faster to keep up with the flow. But it's very important to keep a good view on all the wall of the stomach. And as you see on the left side, there is the tubulovillous pattern of the gastric antrum with a wide turbid band. And on the right side, it's focused on the region of the GIM where you have changes like erosion or increased vascular prominence. All this it can lead to raise the suspicion of having GIM. I'm gonna go talk about epidemiology a little bit. Studies had showed that GIM is approximately 20 to 50% of patients had endoscopy. You will see at least some chronic gastritis changes. Risk factor: H. pylori infection, old age, smoking, and dietary factors like high salt intake, low fruits and vegetables. GIM, it's a very complex interplay. It can be due to very complex interplay of environmental factors, genetic predisposition, and inflammatory responses. The progression involved chronic inflammation, alteration of gastric microenvironment, and genetic mutation like CDX2 and MUC genes. Endoscopic diagnosis: we diagnose GIM with standard endoscopy, chromoendoscopy, MBI. Once we have any concern for that, we should go with biopsying following Sydney protocol. And again, the diagnosis would come from histological evaluation, which we will talk more in the next few slides. The optimized upper endoscopy, again, this may be the most important message of my talk today, is to spend more time in the stomach. And some data suggested that you should spend at least 7 minutes or longer if you have any concern to have a higher detection of rate of dysplasia or neoplasia. Some suggestion of adding simethicone and acetylcysteine could help to have an optimal mucosal feasibility. And again, detailed photo documentation of all anatomical landmark is very important, as we all do. Systematic review of endoscopic techniques improve the detection of GIM, and we all use the high definition endoscopy to help us to find the most suspected area of GIMs. Again, this is some studies maybe suggest to use the optical CT, which coherent tomography, which is the real-time diagnosis of GIM. I don't think we all use that. So it's very important when you have intestinal metaplasia to know the types. I will make it as simple as possible. So it's either complete or incomplete. Complete is still considered benign and less aggressive than incomplete pattern. In this picture, I'm showing you on the left side the difference between incomplete and complete. So the left side is the complete IM, where you have goblet cell over here, and you have the brush borders. Those all suggestive of having complete IM. When you have an in comparison to incomplete IM, there is no brush borders, and also there is mucin staining changes over here. So this is very important to ask our pathologists to comment if we're dealing with complete or incomplete IM to help us deciding about the surveillance. So how to manage GIM? I think it's most of us have at least once a week to see such a case, and there is no actually great guidelines of how to follow those patients. There is some efforts being done here and there, and with some guidance, but there is no strong evidence on most of it. So GIM, most people will say should undergo surveillance endoscopy depending on the severity of metaplasia and presence of dysplasia. Follow-up protocol, again, depending case by case, and we're going to go more in a few slides. How we treat GIMs before it become cancer. It's actually, you have H. pylori, as we discussed in the previous slides, then you have to treat. The efficacy studies showed that eradication of therapy reduced the risk of progression of gastric cancer in patients with GIM. Again, it's very important to also ask the patient to follow lifestyle modification, smoking cessation, and follow dietary changes, more vegetables, more fruit, and that could reduce the risk of gastric cancer. Now, most of us, at least one day, when you do biopsy, you found dysplasia, then it's just pretty simple. If you have low-grade dysplasia, you still can monitor. In general, every 6 to 12 months, I'll talk more in detail in the few slides. But I think if you have high-grade dysplasia, it's time to resect. And it depends on what you see. If you have a small lesion, I would say 1 to 2 centimeters, you have to do it in block, and this EMR can be the way to go, or it could be ESD, depending on how big you're dealing with the area of dysplasia. But again, surgical resection is always the gold standard for such cases. If you have a larger areas of involvement of diffused dysplasia. In the few couple of slides, I was looking into literature to find a great guidance on such patient, and there is even debate in a different guidelines from different area of the world. So clinical practice of the AGA recommend actually with testing of H. pylori and treating that, but they recommend against endoscopic surveillance. Again, this come back to the point of which areas they consider high risk or low risk. In the US, it's still considered low risk to have GIM compared to our area, at least. So I don't think we can apply the same guideline or in the Middle East. Again, we have to know it's incomplete or complete, is extensive or limited, and if there is any family of gastric cancer. This all play a role of how frequent we should do endoscopy. Patients who have racial ethnic minorities, which is probably coming from the East Asia or Middle East, those are a high risk of having gastric cancer. Again, I don't personally agree with this guidelines in our area, because we have a different patient population. So this slide is just saying there is actually insufficient data to optimal surveillance based on indirect evidence regarding cumulative gastric cancer among patients with GIM. The golden rule, if you have low-grade dysplasia, some data is saying you should repeat every 1 year, and some data is saying every 3 years. But I think it's case by case. So I actually found this approach from the British Society of Gastroenterology guideline. It's very nice. And if you have patients with chronic atrophic gastritis, you do systematic endoscopy with taking biopsy following Sydney protocol. If you have low risk patient who are distal CAG in the incisora, or high risk, you have extensive CAG or involving the corpus mostly. So the low risk people, they are suggesting to do no surveillance if you have no family history or no H. pylori. But if you have high risk group, then they're suggesting to repeat endoscopy every 3 years. This slide also, if you have a patient who has a non-visible high or low grade dysplasia, you do a very careful endoscopic examination. If you look for a lesion, try to resect it in block. If you could do ESD or EMR, it depends on what you find. If it's large enough, maybe you consider surgical resection. But if you have non-visible low-grade dysplasia, annual systematic endoscopy with imaging enhancement, and if it's negative, then you go after that 3 years systematic endoscopy evaluation. Again, sorry, this is the high grade dysplasia group. Once you see it, I think you resect. If less than 1 centimeter, you can take it with EMR. More than 1 centimeter, ESD will be the way to go. And if you have more than that extensive area that cannot be resected in block to evaluate the margin, then maybe the surgery would be the best approach. This table is just showing the risk of cancer in patients with gastric atrophy and intestinal metaplasia. Overall is 1.9 of the 5-year incident. If you have a mild disease, 0.7, and severe gastric atrophy is 10%. We all know when you have a high-grade dysplasia, it can go up to 85%. So I think once we reach the dysplasia, when which we reach the dysplasia stage, then we have to really think about either resection or very, very close monitoring to those patients. Now, I will end up my talk with this slide, and this is actually a nice table to compare the ESGE recommendation, the British and the AGA, and it's very nice. I mean, if you have a very extensive IM, there is a no dysplasia maybe every 3 years. That's what they recommend, the ESG and PSG. If you have limited but no risk factor, ESGE is suggesting no surveillance, and the VSG2. If you have limited IM, but you have a family history of incomplete pattern, then maybe every 3 years you should consider doing endoscopy. Limited IM with severe atrophy, still 3 years. When you have a severe atrophy and family history, limited IM, 1 to 2 years. And if you have autoimmune gastritis, it's up to 3 to 5 years. So I will end up my talk with this. I mean, there is no, even with all these guidelines, there is still a debate. Excuse me? There's still the debate about the best approach for those patients. The way I do, I personally do it, and we have metaplasia on a random biopsy. I'll bring the patient back to do a complete mapping to the stomach. And if you have no dysplasia, if you have H. pylori, then you treat it. Then if you have no H. pylori, I think it depends on the family history, where is the patient from, and if you have a complete or incomplete. If you have incomplete pattern, then maybe very close follow-up every 1 year, up to 2 years. If you have complete pattern, then maybe you can go up to 3 years. I think it's dependent on where you practice and what's the rate of gastric cancer on the region that you practice. And in Saudi, I think we consider a high risk area, so maybe more frequent endoscopy would be better compared to just extending surveillance. And by that, I would thank again the organizer, and I'm open to any question.